It's the 12th of March, 2020. Welcome to Kopi Time, a podcast series on markets and economies. And given the times that we live in, matters of public health. I'm Taimur Baig, Chief Economist at DBS Group Research. These are intense times in the markets, to say the least. We have been busy assessing and revising our forecast for variables ranging from economic growth to exchange rates, Fed funds rate to credit spreads. You can find our latest analysis and forecast on multiple channels. All our research output, for instance, is placed in the public domain, accessible through the research tab at dbs.com.sg. We also do a lot of multimedia, ranging from this podcast to short videos to hour-long live stream of our monthly insights. You can find them all under the Macro Insights playlist at the DBS YouTube channel. Now, to today's business. I know Dean Ho because his son Ethan goes to school with my son Aman. We first met at one of the kids' birthday parties last year, and once I heard what Dean does, I was absolutely blown away. And I can assure you, dear listeners, that by the time this show is over, you'll also be blown away. Small introduction, Dr. Dean Ho is the director of the N.1 Institute for Health, as well as the Institute for Digital Medicine at NUS. He is also provost chair professor and the head of the Department of Biomedical Engineering. He got his PhD, MSc, and BSc in biomedical engineering at UCLA. Quite the dedication, Dean. And he has won all sorts of awards. You can see his CV online. I'm just going to tell you that he has recently been elected to the U.S. National Academy of Inventors. Dean, welcome to the show. What a pleasure.
Thanks for having me.
So there's a lot to cover. I think we're going to break down the show in two parts. I was blown away by your February 28 article in Science Journal or magazine about using AI on oncology. So we'll start with that, expand on that. There are lots of things I couldn't quite understand that I want you to clarify. And my understanding is that a lot of the work you do day to day is oncology related, but it's general enough that our current obsession, COVID-19, it has implications for that.
Absolutely.
So let's start with the AI and oncology stuff,
Sure.
and then we'll move on. So, and before we get down to it, why is this UCLA PhD in Singapore? How long has he been here? What brought you here?
So I moved here almost 2 years ago. I was on the faculty at UCLA, and I think what excited me the most about Singapore was the opportunity to engage multiple aspects of the innovation ecosystem simultaneously. And what we're going to talk about in a little bit is the process of drug development, the process of personalizing medicine requires engagement from a broad spectrum of stakeholders. I firmly believe that technology alone will not transform the way that medicine is practiced. So we need to interact with engineers, with clinicians, with regulators, with policymakers, healthcare economists, behavioral scientists to ensure that our technologies are getting used and that use is sustained. And so the faster we can bring all of these parties together, the faster we can bring optimized therapies to patients. And so Singapore is the place for that. And over the past few years, I've had a chance to collaborate with a wonderful community of innovators here. And I thought, you know what, let's make this full-time. And a lot of exciting things have happened.
And did you move by yourself or with a bunch of other researchers?
So I came here and I brought a team of regulatory specialists because I think one of the major advantages of Singapore is that we can engage with the Health Sciences Authority on a very active basis. It's a contact sport. For the technologies that we use to personalize healthcare, we want the regulators to be aware of how we do what we do, how we analyze outcomes, when we look at statistical significance, all of the above. And we've had the opportunity and privilege for our regulatory team from the Institute side to really build a strong relationship with the HSA here.
And you felt during your time in LA that that ecosystem was just not there in the US.
You know, I think when it comes to accelerating better therapies and personalized care to patients, it's important to really, I know the term is used a lot, but to really think outside of the box. And what I mean by that is not just technologically, but to really sit down and integrate ourselves into healthcare and clinical workflows, to understand what are the major challenges of delivering innovative healthcare. How do we pay for it? And a lot of these answers require rapid, immediate discussions. And I think, the U.S. is certainly a foundation for healthcare innovation, but I feel that the environment in Singapore is much more agile. And again, every hour we save, every minute we save, the patients ultimately benefit. And I think when it comes to thinking about reducing the cost of care, the opportunity to move the needle here is very apparent. And right now, even without COVID-19, when we look at the escalating costs of care in the US, they're substantial. And I think that the opportunity to deploy innovative approaches here that will ultimately and very clearly impact the cost of care here is a very exciting opportunity.
That is fantastic. And at one point, I do want to talk about the overall cost for healthcare and how technology can sort of help address that.
Absolutely.
This article that you published in Science, Artificial Intelligence in Cancer Therapy, it feels like 2 pages of text, but a lifetime of research and insights embedded into it. I highly encourage our listeners to read that article, but we will try to unpack bits and pieces of it. So the N.1 Institute for Health and Institute for Digital Medicine, WisDM, it seems to be the acronym, how are their works or the work program related to this article that you've written?
Yes. So for N1 and WisDM, N1 and WisDM use platforms like AI, digital medicine to ultimately do 2 major things, among others, but we accelerate the development of new therapies for many types of cancers, solid and blood cancers. And once we develop these therapies, we want to make sure that we are delivering them in as personalized fashion as possible. We all know that we're different from each other, right? But we are also different from ourselves over time as treatment starts. And so this concept of how we discover or determine the drugs we give to a patient, followed by how we dose those drugs, it's important to move beyond high and fixed dose therapy, which is a mainstay for oncology.
Of course.
The objective is give the maximum tolerated dose, fire as many bullets as possible at that tumor, and you'll get the best outcome. But the reality is, people are complex and people are different from each other. Sometimes a person who may not respond very well to a high dose could actually respond very well to a low dose. And so N1 and WisDM, we harness those technologies that we have in-house, and our ultimate endpoints for our institutes are the patients. Our KPIs are based upon how many lives we save a year. And certainly we will publish, we will get grant funding from that, but ultimately for us, it's about helping the patients.
And hence, N=1, absolutely personalized.
Everything we design, every trial we do at N1 is tailored specifically to the patients that we recruit.
All right, so then we sort of start getting to the heart of the matter.
Sure.
The link between artificial intelligence and cancer therapy. Unpack that for us.
Sure. So the first thing I'll mention is that cancer therapy is represented by many segments. There's drug discovery, the process of discovering new molecules to treat cancer. Then there's development. How do you take that molecule through a developmental pathway? How do you pick the right dose? Many times you need to deliver these new molecules as combinations with other drugs. How do we design these combinations? Ultimately, we go to administration. Once these drugs and drug combinations are discovered, how do we dose them in the clinic? Good drugs, when given at the wrong dose. The general perception is, maybe it'll be suboptimal for the patient. But the reality is, a good molecule, good drug, when given at the wrong dose, may have no efficacy at all. It may even make the patient worse off. And so the biggest challenge right now in cancer therapy is that a lot of these terms are used interchangeably. People think, look, discovery. I do drug discovery. If I have a good molecule, as long as I find a roughly pretty good dose for it, I'm going to be fine. The patients are going to do great. But the reality is all of these segments need to be seamlessly integrated and optimized to truly optimize the outcomes for the patient. And a lot of times there's a lot of crosstalk between these different segments. This is where AI can play a role in each of them.
So in terms of training the AI, we hear all sorts of phrases all the time, whether it's in finance or in your part of the world, machine learning and neural network. How are they relevant in your context?
That is a great question. So training the AI, I think depending on different segments we're talking about, some need different amounts other than others. So let's start with discovery. The process of discovering a new molecule right now is expensive. Actually, the whole process of developing new drugs is expensive. A lot of it takes time, right? Mining data for how certain structures will behave, interact with certain other molecules to inhibit cancer growth, for example. There's enough data where AI can be trained to accelerate the process of designing molecules that might bind a target more effectively, and maybe not bind off target more effectively to reduce toxicity. There's been a lot of exciting work recently where teams can drastically reduce the amount of time to come up with good molecules. And there's a lot of good databases available to help train the AI to find and design these compounds. Moving on to development. This is an area where I think there's a lot of change needed. When we give drugs for any disease, we often focus on the target, right? Target-based drug selection. If you block this target, you're going to block growth. And guess what? If you block 2 targets, it'll be even more potent. Block 3 targets, prevent blood vessel growth to the tumor so it doesn't grow as effectively or doesn't spread as effectively, then you're going to solve the problems. The issue is biology is a lot more complex than that and a lot smarter than that. And so what we do with our AI in development, which is often overlooked, is we can interrogate and study huge parameter spaces. Give you an example. Instead of just 2 or 3 drugs that we think will be good for a cancer, let's look at 15. And for some of these drugs, let's call them left field drugs, drugs that we think would never be useful for this type of cancer. When you think about 15 drugs and the possible dosages in which you can administer them, that is a huge parameter space, totally insurmountable by traditional screening. As an example, if you take drug 1 out of 15 and you apply it to a, say, liver cancer model, and drug 1 doesn't work at all, traditional screening will have us kick that drug out. We'll never look at it again. But what if drug 1, drug 9, and drug 12 at the right dose actually is the best combo of the entire lot? So instead of traditional approaches of picking the drugs you think you need and go looking for a dose, you actually have to find the right drugs at the right dose at the same time. There's the amount of resources it would take to do that if you brute force, if you screen out every possible combination, it's just not possible. With AI, instead of old training sets, we can actually run less experiments to find what we call the global optimum. Given a certain disease, the best drugs and the best doses to go after that. They can't be guessed. The parameter space is too big, right? Now, after we have the combo optimized for both the drugs and the doses, we can then go to administration. Now, for AI, instead of giving a fixed dose at all times and then waiting for the patient to stop responding, we can take the patient's response in a serial, repeat fashion and tailor the dosing over time to make sure we're sustainably optimizing their care for the full duration of treatment.
And this is like on a daily basis?
Great question. It can depend on the type of cancer. It can depend on how often we can obtain measurements of response. And also that's individualized when people respond to treatment. But I would say from a recent solid cancer study we did, we were modulating the dose as often as once a week. And that was, sometimes we would drop the dose, sometimes we would increase the dose. We would always be well below the maximum dosing. And so we are tailoring care using a patient's data on themselves only.
I want to go back to the development question. So there's 15 different parameters in this incredibly large space. This is all computer modeling.
Great question. Actually, what's really amazing about some of the technologies we're using at N1 and WisDM and our biomedical engineering department is that we actually run experiments to drive the optimization. So I think we have a very exciting discovery that was made a few years back, which is that if you take drugs and the dosages, and we'll call them the inputs, and we take efficacy and safety, how big is the tumor, how small is it, how's the patient's tolerability of the drug, if we call those the outputs, we can actually correlate both of those quadratically. It's like a smooth surface. And if we run the data points, we run the experiments that give us the data points to plot that surface, we will be able to find the drugs and dosages that are globally optimal. Because it's a quadratic surface, you don't need to run as many experiments as one think we will need, right? And so in this case, there's a lot of talk about big data, right? There's a lot of talk about training sets. It's not necessarily about the big data, it's how we acquire the data. There's a lot of data that this drug and that drug work really well for this cancer. This drug and that drug work really well for this cancer. Let's just pool all of this together and there's a magic combination. We can do better. We can run experiments prospectively, not using all retro data, to help drive us simultaneously towards an optimum while also telling us which combos might not be as good. And here's the interesting part. For 40 plus different diseases we've done with our platforms, if there's a standard of care, it never ranks number one. Okay, so what's used clinically, and it's not ranked number one, but that shouldn't be a huge surprise, because if we try out 15 drugs instead of limiting ourselves to 2 or 3, we're always going to find a better solution. Right, and we don't need to run that many experiments to get it done. So it's a hybrid of computation and experimentation. So that's why the data is robust.
That is fantastic. I think I told you on the way here that last night I was rereading the Science article, and there were paragraphs where I put exclamation signs. And the stuff that you just talked about, it is possible that people who are not very well versed in mathematics probably did not get what you just said, but I put a double exclamation sign next to the Qpop reference, the quadratic phenotype optimization thing, platform. So if I can break it down into really layperson's idea, that you have a very powerful computer, you have a very powerful algorithm, and you have a lot of variables that you are trying to calibrate against. And you're using very clever mathematical technique to make sure that it's not just brute force, but there's some smarter modeling involved in coming up with an optimal solution.
That's correct. I think for any disease we're going after, we want to what I call stretch the space. If we're sitting in a room, you got the walls, you got the ceiling, and this room represents all the possible drugs and dosage combinations we can apply to a certain cancer. It would take forever to find the best possible dot, if you will, in the room. But the way that, as we say, the quadratic phenotypic optimization platform, or Qpop as we affectionately call it, it allows us to stretch the space to know just how big this room is, but then gives us the key data points from which we can create a map, if you will. And that map will tell us exactly which drugs at which dose from that entire space will give us the best possible outcome. And the thing is, Qpop ranks it all out. It'll give you the best all the way to the worst. For some people, maybe some of the drugs in the top combination are going to be too toxic for them. And so we can always go to drug combo number 2. If that one were to say fail over time, we'll go to 3. It is both personalized and what I call dynamic repurposing. We can take new drugs too, but we're effectively able to design personalized regimens on the fly so that we'll always be prepared for what is a very dynamic situation for patients.
And this kind of work also has applications when you're trying to match patients to clinical trials.
Absolutely. I think one of the biggest challenges and a big contributor to the cost of drug development is that when patients are recruited into trials, first of all, for the benefit of the patient, it would be great to know if there's a way that they'll benefit from the trial. And certainly for the cost of development, we want to make sure that the costs that contribute to failure are being minimized, right? And so using things like Qpop, if a patient's biopsy can be obtained, we can very quickly find out what drugs this person will respond to. And if, for example, a combination that's being trialed is in the works, we'll be able to know, fairly confidently if that person will be able to respond to that combination.
And this is not just in theory, you actually have done this.
This has been done. So the beauty of N1 WisDM biomedical engineering is that we're effectively clinical stage, which means almost all of our studies, 99% of all the studies in these institutes and department are clinical stage, are all in patients.
So there are patients in Asia right now, or perhaps even the United States,
sure,
who are part of your
Absolutely. So there are patients in Singapore, there are patients in China, Frankly, we are now approached very frequently by clinicians and patients from around the world, U.S., Australia, U.K., India, you name it. And it's a very streamlined process in terms of how we find out what condition they have, how we may be able to help. It's a very collaborative process with the clinicians, patients in Singapore, patients everywhere, under the care of Qpop and Curate AI, among other platforms that we have.
And not just for a specific cancer, but for a wide range of cancer patients.
That's correct. What's cool about our platform is that it is agnostic. This correlation between drugs and doses in, efficacy out, we don't have to build models depending on the disease, right? So if somebody comes to us and says, this person has liver cancer, can you help? We ask simple questions. How do we measure response? What are the drugs you need? Can we change the dose? And we can design studies very quickly. And the beauty of all this, you had asked earlier, moving to Singapore, we have gotten clinical studies approved personalized to single patients in 16 hours. They are rigorously reviewed, strong collaborations built with not just the technical side, but the regulatory side, because time matters. Time is not something everybody has a ton of, right? And so it's an agnostic platform.
And how revolutionary is this? I mean, have cancer research efforts been like this in the past, or this is a new thing?
This took time. First off, I'll say that we don't require big data. We don't require complex information about the biology, because this map that I'm talking about directly relates drugs and dosages all the way to the end, which is efficacy, shrinking the tumor. In between that, there's a lot of stuff happening, right? Everybody has their unique genomics, pharmacokinetics, how long the drugs stay in the body. It's all individualized. But it doesn't mean we ignore that information. We actually complement very well with researchers in the big data space, because a lot of their information can help us pick which drugs we even put into the platform in the first place, right? But the fact that we don't require a lot of that information means we can deploy ourselves and start immediately for basically anybody, and not for any cancer basically, as well as other diseases as well.
We're going to come to the other diseases later on.
Yes.
All right, so you've used artificial intelligence to develop drugs. You have used artificial intelligence to match patients with clinical trials. Now the trial begins. And walk us through how you're working with the patient at that point.
Sure. And so, I think one of the biggest challenges with clinical trial design is that, again, when people think that there's a good molecule, depending on how you assess that molecule in trials, that's really, at the end of the day, whether that drug's going to make it or not. A lot has to still be done during that development stage to optimize a new drug. Right now, when a patient comes in for trial, they will often be randomized into a certain dosing cohort, meaning this patient comes in, they'll be randomized to a low dose, middle dose, high dose, and doses in between. Here's a challenge. If a patient gets put into a high dose cohort, and let's say they don't do very well, the disease gets worse, they have huge toxicity issues, they'll often be removed from that trial. Sorry, the drug didn't work. We will have never known if that patient could have responded to a lower dose, right? And the thing is, for us, instead of getting 100 people and giving them the low dose, a different group of 100 giving them the middle dose, and a different group and giving them the high dose, what if we gave each person the low, the middle, and the high? That's allowed, by the way, right? There are study designs that allow us to expose patients to different types of drugs. In this case, they're getting the same drug, but at different doses. We know it's okay because there are patients that are getting the low dose, the middle dose, and the high dose. If I calibrate each patient with the low, middle, high, I am certain we will find more response from the patients, because some people might need the lower dose when instead they're being given the high dose, and vice versa. One of the patients that we did treat with Curate AI was given a fairly high dose of this phase 2 drug, and we quickly found out that by dropping the dosage of that drug by 50%, we increased their efficacy. In oncology, right, when we talk about standard of care, dosing changes are usually guided by toxicity events. Oh, it's too toxic, let's drop the dose. When do we drop the dose to increase efficacy? So that there was a game changer. right? And so I think in terms of practice-changing healthcare, the ability to guide oncology dosing using efficacy with AI will be profoundly important for clinical trials, because we want to have more patients respond to that drug, right? And if we can do that faster, ultimately the cost of development goes down, everybody wins.
Well, the other complexity that we always hear in clinical trials or even real life administration is the body developing immunity.
Yes.
And resisting drugs.
Yes.
Do you have any tricks up your sleeve to deal with that?
Absolutely. And so I think this is where Qpop, as well as Curate AI, can come into play. As we know, Qpop is generally the drug selector. We use that to optimize which drugs go into a combo. Curate AI modulates the dosing. When we do Qpop, we come out with a ranked list of best to worst. And so it's very possible, let's say we use a combination from Qpop and the patient develops resistance, that we can just move right down the list to a combination that does not contain that drug. But at the same time, when we use these combinations and then we move them to Curate AI more often than not, or more or less all the time, finds lower dosing to optimize care. And so when you combine picking the right drugs at lower dosing, the lower dosing aspect could very well either delay or prevent resistance as well, right? So it's a multifaceted approach to combat resistance.
And among the other places in your article where I put big exclamation mark was the game theory aspect.
Sure.
I mean, I just couldn't believe it that in a discussion on AI and oncology, I will see game theory application. I mean, walk us through that, because I was blown away by that.
Sure. There was amazing work occurring in Florida using game theory in the sense of a team is competing against a tumor. And when high dose therapy is used, and high dose is the standard of care, the notion there is that drugs that are sensitive, that respond to that drug, they'll be wiped out. Makes sense. You've got a lot of drug, you've got these cells that respond to the drug, and they're all wiped out. But there are, by virtue of resistance, cells in that tumor that are still going to be around. And if we wipe out the ones that respond, if we think about a tumor as like a community, and there's food, right, that's sustaining this community. Well, now that we've wiped out all the guys who respond, you've only got resistant cells, and they start to overtake that population, right? And so what if dosing can be modulated in a way where we keep some of those that are, sensitive around, for example, so they can continue to compete against each other to use up resources? We can suppress resistance, delay it, maybe prevent it, right? And so the concept of game theory or adaptive therapy is to use alternating dosing approaches to try to keep a fine balance between what comprises that tumor. Examples include giving a bolus or a big injection of something and then doing a low dose of something. This interplay of which cells make up a tumor, if we can keep that balance maintained, it's very possible, this team's wonderful work at Florida to make cancer potentially a more chronic type of management scenario. Not go after all of it at once, but suddenly you get resistance, and then that's where problems happen, right? It's taking a balanced approach.
That's amazing. So let me see if I sort of understand it.
Sure.
So from my behavioral science background, I think of game theory as a bunch of actors, and they have their own optimization, maximization functions, and we will play a game to see, if this person's incentives are aligned with somebody else's incentives. Here, the drug is an actor, the target cells are another actor, and you are trying to game the way they will interact with each other.
Yes, and there's many type of target cells, those that respond and those that don't respond. And being able to maintain that balance is what allows the management of this cancer to be sustained.
And we have seen efficacy out of this approach.
And that study, they ran a really cool study in prostate cancer patients where they were able to show lower dosing as well to sustain treatment efficacy. And then there's a whole separate component of lower dosing. Maybe there's a chance to reduce the cost of care as well.
So all of this fits under the umbrella of adaptive therapy.
Yes.
You're customizing N equals 1, and from the drug development to administration to the trial, everything is highly specific to the patient.
Highly specific to the patient. It's just that certain methodologies differ a little bit. Some of them use more population principles, where if a tumor doesn't change by a certain percentage or does change by a certain percentage, we apply these dosing parameters, which is great. With platforms like Curate AI, we dynamically modulate depending on different dosages just by seeing how this patient responds, and the dosing that we give back is tailored truly to them. Right, so it's a model-less approach. There isn't a population set of principles to apply based on how they respond. There are differing levels of personalization, but compared to standard of care, they're both very exciting.
Okay, just a very personal question. Did UCLA prepare you for this sort of work? I mean, did you pick up all these tools in your master's and PhD, or you have to pick this up by yourself later on?
That's a great question. And so, the exciting part of healthcare innovation is that what I learned at UCLA actually didn't have much to do with this at all. After I graduated from UCLA, I spent a little bit of time at Caltech, and then I started my academic career at Northwestern. And Northwestern was a wonderful place because I had a chance to just interact with amazing chemists, biomedical engineers, mechanical engineers, clinicians. But I actually started out in nanotherapy. We were using tiny diamonds called nanodiamonds to deliver drugs. And then from that, it evolved in this notion that, look, even with nano or any type of drug delivery, combinations are going to be needed. How are combinations designed now? Pick a couple drugs, go look for a dose. There's got to be a better way. So we ended up working with an amazing team of mechanical engineers, control theory people, mathematical oncologists, clinicians that were thinking there's got to be a better way than high-dose therapy. And so it was this evolution that at UCLA, when I became a professor there, we started to take shape with a group of multidisciplinary researchers. And then once we had done some initial validation, coming to Singapore was really where this took off because there's a whole separate segment of the policy side, healthcare economic side, talking to clinicians who understand the challenges that need to be addressed to really reduce the cost of delivering optimal care. And we're able to really move the needle here, and that's what's exciting.
Yeah, that's fantastic. We could spend this entire podcast talking about AI and oncology, but the times that we live in, we are highly distracted by COVID-19.
Yes.
All this work that you do, is it cancer specific, or there is something you can tell us interesting, hopeful, insightful about COVID-19?
That's a great question as well. This draws complete parallels to COVID-19. A lot of the same challenges that confront infectious diseases, oncology, a lot of them are the same. I'd long hoped that the world would pay a lot more attention to infectious diseases before they become global challenges, right? But the fact of the matter is, certainly oncology gets a lot of attention. But right now is a time, I think, for the clinical community, the technology community to rally around a problem that I think is going to be around for a while. Because if it's not COVID-19, it could be COVID-20, 21, something else. If we look at the challenges of infectious diseases, time is also a problem because these issues ramp up quickly. And when they do, a lot of the same terminology pops up. Hey, let's use AI to discover a new molecule for it. Let's discover vaccines. Let's develop other platforms to address this disease. But the challenge here is viruses and other bugs, they can change quickly.
As in a mutation.
As in mutations. And there's already different types of strains of COVID-19. And what has to happen now is, if we look at the world, economies are overburdened. If we look at the growth rates of R&D costs for new drug development, and we look at the growth rates of revenue from these new drugs, there's a mismatch there. It's not sustainable to spend all this money to develop new drugs. Now, of course, I understand, right? When pharma develops drugs, when they collect revenue from that, so on and so forth, that drives future R&D. So I fully understand and support that. But we need to do things faster, and we need the outcomes to be optimized. And so not long ago, we actually, out of N1, WisDM, and biomedical engineering, initiated something that I call Project Identify, which is the opportunity to use AI to develop optimized combinations for infectious diseases.
When was this?
And this was actually started up right around January.
Oh my.
And this was amazing as well. We initiated a project to take a set of 12 drugs, and some of them are antivirals, some of them are anti-inflammatories, but all of them have previously shown to have some potential antiviral effect. And so we said, hey, look, can we use our AI to optimize repurposing? That's a big difference from just repurposing. Every day there's articles for cancer, for diabetes, for infectious diseases where they say this molecule for diabetes may be able to treat cancer. That's exciting, but that's not enough, right? We have to find, as we know now, the right drugs at the right dose together. And so we worked with a partner in China who's an expert in infectious diseases. And we said, look, let's take these 12 drugs. Let's take this viral model. It's an RNA virus. Use it as a surrogate first, because right at the time, teams around the world, including Singapore, were developing strategies to study COVID. I said, let's do a proof of concept. Let's take this virus model, 12 drugs, and let's see if we can optimize combination therapy against it, and let's see how long it takes. 12 drugs, dosing, that's a big parameter space, right? And again, we're not taking the 12 drugs and individually seeing if they work and throwing in some random combinations. We are interrogating the entire possible drug and dose space.
The full spectrum of dosage.
The full spectrum of dosage plus drugs, which dose. And in 3 days, we ranked out from best to worst the combinations. And here's the interesting part. We found that if we were to take the best ranked combination and we simply tweak the dosing from optimal to slightly not optimal, huge differences in efficacy. Okay, and we know this. We know that dosing matters, but this study shows us that we cannot simply take some drugs that we think will work and just add them together and think that everything's going to be okay.
So Dean, again, this is in a computer model.
This is experimental. So all of this, we actually had the experiment
Petri dish
in the lab.
So you have a wet lab?
So I have a wet lab. Our institute has a wet lab, but we actually partnered with a lab in China at the time. And this is an exciting part of the story in that when we decided to do this, we knew we didn't have a lot of time.
Correct.
And so our lab, our partner in China was set up to run some of these experiments. The analytics, both of our teams did. And what was really neat is, at the time it was Chinese New Year. And unbeknownst to that lab, they were going to be shut down because of the soon-to-be massive COVID challenge. And so we needed help in getting them the right therapies to run the study, or else if we had waited even a couple weeks for them to do the shipments after Chinese New Year, the study would never happen. And we had amazing support from our Office of the Deputy President for Research and Technology to provide us guidance on how we were able to procure the therapies and get them to our partner. But we also consulted with the HSA, the Health Sciences Authority, about how do we make this work and so that we do it all by the book, right? And so we got guidance from all of these parties, and I'd say within 3 hours or so, we had all the resources we need. We got the study started up within a couple days, and then within 3 days after that, basically, the study was done. Right, and then right after that happened, the shutdown happened, right? And so this proves the level of teamwork that's needed in urgent times to rally around and intervene optimally, right? And so next up is COVID. So literally next week, we're talking to the people who handle COVID, and this is agnostic. So we can apply this towards anything immediately, right? There's a lot of talk about how do we go after COVID, but under restrained, austere conditions, we have to take the resources that we have and act quickly. So that's why I call this dynamic repurposing that's optimized. Give us a pool of drugs, we'll find the optimum within a few days. If a few months later the bug seems to have evolved into something else, give us another few days, we'll reevaluate what drugs, we're back at it again. We'll have a new combo ready. Right, we need to be that dynamic to really address COVID. They've had patients who apparently have been discharged, they go home, but then they test positive again later. We need to sustainably and dynamically repurpose on the fly. And when I say repurpose, I mean optimized repurposing.
So the drug that you developed within 3 days, is it being used in China?
So we developed a combination. The drugs are approved for other diseases.
Correct.
And so, but the combination, the multiple set of combinations we developed within those 3 days, that study was to show that we could do this for an RNA virus, a surrogate model. What we will do next is we'll take the actual COVID virus and redo the same study within a few days, have a ranked set of combinations. At that point, we will be interacting with the clinicians to say, hey, look, so we found that combo number 1 is actually the best. Are there patients that we think should be trying this combination? And from there, we will design clinical trials.
Okay, Dean, the world is waiting. I mean, what's the timeline?
Absolutely. So I think that if we get everything ramped up on time, I think within the next 2 to 3 weeks we'll have combinations done, and most of that is just administrative and prep time. A few days, the whole experiment's ready to go. It's done.
And then you move to clinical trial.
And we'll go to clinical trials.
What is the state of COVID-related research in China right now? Do they have clinical trials going on already?
Absolutely. There are a number of clinical trials. As of even a month ago, there were at least, I believe, 60 trials ongoing for different approaches related to COVID-19, ranging from repurposing to some exciting new molecules that have been developed by various companies around the world. And I think that, first of all, it was great to see mobilization. But I think that to really give the best possible outcomes for patients, we have to think about, again, optimization. Because good drugs, wrong dose, there could be no efficacy. And to simultaneously pinpoint drugs and dosing, the outcomes will be very different. And so this is what excites me about what we're doing now, and our opportunity to partner with some of these companies to take their therapies and put them into our platform is, again, rapidly, dynamically optimized repurposing.
For the benefit of our listeners, I want to sort of divide the subject into 2 parts. One is a vaccine for inoculation. Mm-hmm. We're not talking about that.
We're not talking about vaccination. There's some exciting efforts going on there. It's going to cost a lot of money to work on the vaccines. Fortunately, there's at least one phase 1, probably more that have started up already.
In China?
This one, I believe, is in the United States. Okay. And there might be others around the world, certainly. And here, even, I think there's some wonderful teams developing vaccine approaches here. It's just, it costs money. And our ability to, again, dynamically address what will be a continuously evolving pathogen is important. And when we think about the economics of it, when it costs money to develop a vaccine, the stakeholders that are developing it, a lot of them may have to come together to do this. And we already know governments are overburdened with many things right now, right? Drug development's already a very expensive process. We're in a position to take what we have already and reach unprecedented levels of efficacy. Right? Do more with less, as one of my buddies here says, and this is exactly what we have to do right now.
So your point is that for the time being, inoculation is out of the window. We got to deal with people who are getting sick, and we're going to figure out how to optimally dose them.
Exactly. I think right now, for sure, the vaccines are still very early in development, and when they're ready, we should use them, absolutely, and we'll be waiting for them. But as we think about future now pandemics, we have to have strategies to intervene quickly but optimally. It's a very different outcome that we're going to see versus, hey, let's just try this, let's just try that. There's a lot of noise in the beginning, right? And we don't know what's really working. But if we can move the needle and say, let's just start with something optimized, right? Get a team together, pick the candidate therapies we're going to use, make the combos, and while we're doing that, and we even have the ability to adjust and adapt as the next set of vaccines are being developed or antibody therapies, we'll have a much more measured approach that will ultimately benefit the patients and economies and governments and healthcare infrastructures.
You touched on this issue earlier a little bit. I just want to go back to that. In your view, vaccines are something that the public sector needs to be involved in because the incentives are not exactly aligned for the private sector?
Absolutely. I think that's a recurring discussion that comes up, is that incentivizing development, especially in the infectious disease space, is a recurring challenge. In the United States, there are a number of policies and programs set up to get companies to get into this space, and it's challenging because companies don't want to spend the cash often to develop something that will not return their investment back that they need to develop future iterations, right? And so I think that a multifaceted buy-in is going to be critical. And again, this is going to happen. This will happen again in the future.
Of course.
And if we look at the markets now and what's happening, the world is going to have strategies in place to really respond quickly and in the right way.
Just want to go back to something that I forgot to ask you earlier when we were talking about this. You had said something about the combinations that your AI develops are deterministic, not probabilistic. Can you remind me what you were telling me at that point?
So a lot of when we develop combinations, we get a lot of questions in terms of, are we using computers to predict based upon how drugs interact, based on old data of how these drugs interacted with cancer cells or viruses? And are we using that to kind of predict combinations and then cross our fingers and hope that this stuff works when we actually give it to cells? So that's not what we do, right? What we do is we will set up an array of actual experiments that will effectively paint out the entire drug dose parameter space, if you will, our room that we're sitting in, from which we can quickly identify best all the way to worst. We simultaneously get the data which drives us towards the optimization back and forth. So we are implicitly arriving at an answer. There is no finger crossing. When we say we're going to take 12 drugs, 15 drugs, apply it to this model and optimize the outcome, it will happen every time. Now, that optimum will be different depending on what drugs we try. That's why we put a lot of care into determining what drugs go into the candidate pool, right? But if you give us a set of 15, we don't even need to know what drugs they are. If someone hands us a vial of 1, 2, 3, 4, 5, 6, all numbered all the way to 15, A, B, C, D, E, F, G, and as long as we have some rough idea of the dosing range we should look at by the end of that experiment, which could take anywhere from a few days to a few weeks, we will say drugs A, F, and G is the top combination. B, L, and K, best combination, right? We will always come up with an optimum every single time.
Wow. Now, all this computational power and all these interesting techniques, here's the challenging question for you. Have you guys managed to increase life expectancy of cancer patients in the last 2 decades, or are we flatlining?
I think that the work remains to be seen. But if we look at what we've done so far, I'm going to actually take a small deviation from oncology. We first did this in liver transplant patients, where we were optimizing the dosing of their drugs to prevent rejection of these new livers. And again, right now the dosing is done by titration, where the goal, the objective here is to get the drug in a nice target range. And these target ranges are specific to that patient. Right. If the drugs are too high, they can have neurotoxicity, they can have seizures. If the drug level is too low, they can reject the organ. And so we used our Curate AI platform to do this, and we ended up discharging our Curate AI treated patients on average about a month earlier compared to the standard of care. And this was in the US. 30 days less in an ICU at a hospital in terms of cost of care, in terms of reduced complications. It's not only the money, it's getting immunosuppressed patients out of the hospital faster so they don't get infections that could potentially kill them, right? And so days in hospital is not an actual endpoint measure for success in transplant, because different hospitals get patients out at with different durations. But this was a first-in-human type study, and we could see clear benefits both economically as well as medically. And so if we approach our future studies with that mindset, let's go to oncology. What are we doing with oncology? Our goal is to find dosing dynamically that will sustain optimization, reduce incidence of resistance, reduce complications that can also shorten life expectancy. And we run studies there, and we've seen positive outcomes across the board. The goal now is to get more patients treated for a broader range of cancers. So we have trials set up for blood cancers, for solid cancers, gastric, colorectal, et cetera, et cetera. Now's the time to prove it all out with much larger cohorts. But I think we're going to get there. I mean, all of our data already shows us we can do better with lower dosing at certain points in time for patients, especially for Singapore, where we look at if we reduce the dosing, the subsidy costs go down, reduce complications, better tolerability. We're thinking about impacting multiple facets of this healthcare workflow.
That is just absolutely brilliant. So we're not just talking about quality of care, which is super important.
Absolutely.
But we're talking about the sustainability of spending on healthcare.
That's right.
As you come up with more optimal solutions, the cost and the quality of care.
The outcomes.
And the outcomes.
Imagine lower cost of care, optimized outcomes at the same time, right? That's a massive benefit to all the stakeholders in this system.
Dean Ho, we are very lucky to have you in Singapore.
I'm fortunate to be here. It's an amazing community.
This is just, I wish we had done a video, Martin, who's our producer, because people would have seen my jaw dropping repeatedly during the course of this conversation. Please come back. We want to hear about the progress on COVID-19 with the doses that you guys are working on. And of course, best of luck with all this amazing work you're doing with AI-driven oncology.
Thanks for having me.
Fantastic.
Thanks.
Thank you. You've been listening to Kopi Time with Taimur Baig. That's it for today. Thank you for listening.